Good evening. I'm Henrietta Kotlas-Rosenberg. I'm the Director of Pediatric Radiology at the Mount Sinai Medical Center in New York City, where I'm Professor of Radiology at the Mount Sinai School of Medicine. And I'm very pleased to have the opportunity to speak with you now on the workup of urinary tract infection in infants and children. Urinary tract infection is a very common problem in infants and children. The learning objectives of this lecture are to identify the various causes of urinary tract infection in pediatric patients, to describe the imaging findings in upper and lower urinary tract infection, and to describe an appropriate algorithm for workup of urinary tract infection in various age groups. Bear in mind that pediatric patients are not small adults, and we have to approach them quite differently than we would with the older patients. It is not always easy to get their cooperation, and it's extremely important to provide a child-friendly environment. We're often cajoling them, entertaining them with Game Boys, DVDs, toys. We even bribe them with lollipops. But one has to have a lot of patience, understanding, and lots of love to try to get the cooperation that we need in order to use ultrasound to get the most information to help determine the etiology for the child's symptoms. The younger babies tend to present with fever, foul-smelling urine, and irritability, while the older children may actually articulate the fact that they have abdominal or pelvic pain, back pain. They may describe nausea and vomiting. They may also present with urgency, frequency, dysuria, hematuria. At times, children who are trained will suddenly develop incontinence, enuresis, and there are others who come in with failure to thrive. In order to make the diagnosis of urinary tract infection, one must have a properly collected specimen. In the child who does not have urinary control, a catheterized specimen is necessary. And at times, but very rarely, it's necessary to get a suprapubic aspiration if the urethra cannot be cannulated. In the patients who do have urinary control, a clean catch midstream is sufficient. And if one finds over 100,000 colony count in this type of specimen, the diagnosis of urinary tract infection can be made. From a cath specimen, over 10,000 colony count is sufficient, and in a suprapubic specimen, any bacteria is diagnostic. Early diagnosis of urinary tract infection is important so that treatment can be instituted quickly in the attempt to prevent renal damage. There are several predisposing factors. The virulence of the infecting bacterial organism is important. Particularly P. fimbriae E. coli adheres to the urothelial cells. The bacteria secretes endotoxins which can cross the mucosa and go into the muscle of the ureter, resulting in paralysis, and ureteral peristalsis is remarkably decreased. When there's slow flow in the peripheral ureters, the adherent bacteria are not washed away, and there is an increased risk of ascent and reflux of bacteria into the upper tracts. Some uncommon organisms can predispose to urinary tract infection, things like Klebsiella, Proteus, Pseudomonas, Enterobacter. If there are compromised host natural immune defenses, or if the feces are colonized by virulent bacteria, there may be a higher chance of urinary tract infection. Little girls are infected more often than boys due to the ease of introital contamination. In boys who are uncircumcised, there is a 10 times the incidence of urinary tract infection than in those who are circumcised. In patients who have reflux, urinary tract obstruction or cannot empty their bladder properly, they have a higher chance of developing urinary tract infection. There are multiple imaging modalities available for children with urinary tract infection at the time of diagnosis, as well as follow-up. Ultrasound is the modality of choice to begin the evaluation, and in many institutions, VCUG, voiding cystourethropy, is the next step. Some institutions use nucleocystograms. At times, one needs to use renal scans. Excretory urography is very rarely used, and for problem cases, we may resort to CT and MRI. It's important to examine the bladder in the beginning of the examination so that one can assess the capacity, the wall, the distal ureters, and then ultimately measure the post-void. Many children will empty their bladder as we come near them to scan them, and so if that happens, you can just give them a bottle or a drink, and by the time you're done examining the kidneys, the bladder should have refilled. As for the kidneys, we can look at the size, the contour, look for scarring, examine the echotexture, and so far as the collecting systems, we can generally see the distal ureters if they are dilated. By using decubitus positions, we can attempt to see the ureters between the pelvis and the distal end of the ureters. They are much more easily seen when they are dilated, and in fact, when they're not, we have very little chance of seeing them with ultrasound because of the surrounding bowel gas. And then we need to look at the urethral area and, of course, to look for anomalies. Always include the bladder. And bear in mind that when the bladder is full, that the collecting systems can have physiological fullness. So it's important to examine the collecting systems prior to voiding and then after voiding, when they will decompress in the normal situation. Now, as to bladder capacity, there are two equations that can be used. In the patients who are less than a year old, if you take their weight in kilos and multiply it by 7, that's an estimate of what the normal bladder capacity would be. If the children are older than 1 year, the age plus 2 times 30 will give the bladder capacity in cc's. As a rule of thumb, babies within the first few months of life will have a bladder capacity of approximately 30 to 50 cc's, and it increases over the years until by 10 years, the bladder capacity will be approximately 300 to 400 cc's. Always examine the wall. Look to see if it's smooth, if it's thicker than it should be, and always look for the trigone, which we can see here on the right and here on the left, and we can confirm that with color Doppler to see the jets. The urethra can be easily seen by using a suprapubic approach and angling down into the inferior aspect of the pelvis. In a little boy, we'll see some of the prostate around the urethra, and in the transverse view of the bladder, we can see this very slender bow tie hypoechoic area that represents the seminal vesicles. Remember that we can watch patients as they void even though we're using ultrasound. Here we can see the urethra as a mound of tissue inferiorly and posteriorly, and during the process of voiding, we see that this area opens. Likewise, we can do the same in a male by using a linear probe right over the penis and have the patient void into a urinal, and the urethra will distend up and can be examined accordingly. Remember to look at the uterus when you have a little girl baby, because it's important to know what the length is, the configuration, and the endometrial stripe, as it differs in various age groups. In the newborn, the uterus is a rather prominent structure, measuring approximately 3.5 centimeters in length, with the cervix being quite prominent compared to the fundus. So the fundus to cervix ratio is about 1 to 2. It's not unusual for the endometrial stripe to be thick, and also it's not unusual to find fluid within the endometrial canal. In the prepubertal uterus, the uterus is actually smaller than in the newborn due to the decrease in the hormone level once the neonatal period is over. And the length is generally from about 2.5 to 3 centimeters. It's a flat structure, and there's a 1-to-1 ratio of the fundus to the cervix. If the endometrial stripe is seen, it's generally a very slender structure, and we should always look for the vaginal stripe as well, and here's the urethra. In a mature female, the uterus is longer and will measure somewhere around 5 to 8 centimeters, with the fundus prominent compared to the cervix and the endometrial stripe varying depending upon the time of the menstrual cycle. It's important to determine if an infection is an upper urinary tract infection or a lower urinary tract infection. So as we look at the kidneys, we're going to look for size, we're going to look for the contour, the parenchymal echogenicity, scarring, and also for the collecting systems. Be aware that in the newborn baby, the echogenicity of the kidneys differs from what we see in older children and adults. The cortex of the kidney is isoechoic with the adjacent liver and spleen, and there is accentuation of the medullary pyramids. There isn't a lot of fat in the young baby's kidney, so we see a very faint renal sinus echo and a very faint white line around the kidney representing the perinephric fat. During the next 3 to 6 months, the echogenicity of the cortex decreases compared to the liver and spleen, but there should be definition of the corticomedullary junctions. Know the appearance of the infant adrenal gland so it won't be confused with the kidney. The infant adrenal has a hypoechoic to almost anechoic cortex with a bright linear medullary stroma. Remember that some babies will have lobulation of their kidneys, and this may persist into childhood. This is fetal lobulation. Others may have a very prominent mid-lateral portion of the kidney, particularly on the left side, that has been described as a dromedary hump. Always look for the medullary pyramid within that so that you will know that that is normal renal parenchyma. And don't confuse the ranunculus with a scar. The ranunculus is this little line that you see going from the periphery of the kidney to the renal pelvis that is actually fibrofatty tissue that forms during intrauterine life as the two renules are fusing. And this is known also as the junctional parenchymal defect. It's easier to see on the right side, and it's easy to differentiate from a scar if you know what its normal appearance looks like. Remember, with a scar, there will be decrease in the tissue in the periphery of the kidney. That doesn't occur with the junctional parenchymal defect. Have a chart that you keep near where you read so that you can look at renal size and assess growth. When you see children coming back with urinary tract infection follow-up exams, it's essential to be sure that you know whether or not the kidneys are growing properly. And the chart that we use, that was published in AJR in 1984 by Rosenbaum et al., has the lower limits of normal, the upper limits of normal, that are very helpful in terms of looking for signs of compensatory hypertrophy or inappropriate growth. Now, there are some disadvantages of ultrasound. In acute pyelonephritis that is not as sensitive as other modalities, we obviously can't assess quantitatively renal function, although when we see normal-looking parenchyma, we can qualitatively hypothesize that that kidney should have normal function. We may miss tiny cortical scars. We may miss ureteral stones in the absence of hydronephrosis, and we may miss fungal infection in the absence of hydronephrosis and fluid outlining a fungus ball. Just a few words about the VCUG, voiding cystourethrogram. A preliminary KUB, or a saved spot film, is obtained just to get an idea about the bowel gas pattern, anything to suggest a mass, anything to suggest calcifications or bony abnormalities that might indicate a neurogenic problem. The bladder is catheterized using a sterile technique, or if the patient has a very tight phimosis, a blind catheterization will be done after cleansing the external genitalia. keep a note of what the bladder capacity is, and also assess the wall for thickness and contour. One must get filling films and voiding films and look for reflux as well as grade it. Look at the urethra and also post-void. In boys, we like to get the urethra imaged with the catheter in place as well as afterwards without. And we do 2 cycles because reflux may not happen in every cycle that we look at. Remember that there are some little girls who will come in with labial adhesions and it may be impossible to catheterize them. Premarin cream is used to lyse the adhesions, and this may in fact be the cause of their urinary tract infection. So here's the preliminary scout film, the AP view of the distended bladder, the oblique view during voiding, and then the post-void for residual. Now, voiding films are important because some children only reflux during voiding. Remember that reflux and ipsilateral obstruction may coexist, so that there could be a ureteropelvic junction obstruction, there may be a primary megaureter, posterior urethral valves, and at the same time, the patients may have reflux. Reflux is generally treated with a prophylactic low dose of antibiotics. The International Reflux Study classification is applied as we do VCUGs. When it's only into the ureter, it's grade 1. When the reflux goes all the way up into the collecting system, but there's no dilatation, that's grade 2. With grade 3, there is mild to moderate dilatation of the ureter. There's some tortuosity, there's slight blunting of the calyces. With grade 4, with grade 3, there is mild to moderate dilatation of the ureter and the pelvis, and there's slight calyceal blunting. With grade 4, there is moderate dilatation of the collecting system, and there's tortuosity of the ureter with blunting of the calyces. With grade 5, there's marked tortuosity, marked dilatation, and there are no papillary impressions on the calyces so that they appear convex. Reflux tends to occur in families, and so the siblings are generally screened. There is usually an underlying anatomic cause in the girls because of an abnormal insertion of the distal ureter at the ureterovesical junction. It's postulated that in girls there is a steeper angle, so there is less bladder musculature surrounding the ureter to function as a sphincter. As the little girls grow, this abnormal angle of insertion diminishes. It's not unusual for girls to have spontaneous resolution of their reflux by the time they're 5 years of age. This phenomenon does not occur in boys due to the presence of the prostate gland. Secondary reflux can develop when there is a diverticulum at the ureterovesical junction, a Hutch diverticulum, in patients with dysfunctional voiding who have a neurogenic bladder or have problems with the bladder sphincter dysenergy. Vesicoureteral reflux can be suspected on ultrasound in this patient who had dilatation of the renal pelvis as well as the proximal ureter. It was clear that the ureter was quite dilated and that there was a gaping ureterovesical junction. And one can also look at the peristalsis of the ureter to determine which direction it's going in. At times, vesicoureteral reflux will be suspected because there are changes in the size of the intrarenal collecting system as one is watching, holding the probe stable in a particular position. Here we see some dilatation of the pelvocalyceal system. Within seconds, it looked like it was normal. This patient had a grade 3 reflux and had a normal urethra. Always compare the size of the kidneys. They really shouldn't be more than approximately 5 to 8 millimeters different. And here you can see the right one is small, the left one is a normal size, and on the right side there is grade 4 reflux, and you can see that there is quite a small right-sided kidney compared with the normal left side. Just to look at the VCUG for various grades of reflux, here it is just into the ureter. Here we see the reflux into the entire collecting system, but no dilatation, a little hutch diverticulum associated with grade 2 reflux. Here we see some tortuosity and fullness of the ureters with some fullness of the calyces in grade 3. With grade 4, there's more tortuosity and dilatation, but still some maintenance of the calyceal concavities. There's also some intrarenal reflux here, and with grade 5, there's marked tortuosity of the ureter. Now, there are institutions who do nucleus cystography, and there's a lot of controversy about whether to do it or not. It's believed to be a lower radiation dose to the patient, but using digital fluoroscopy, we can keep our study down to a very short number of seconds. But this is sometimes done as the first study in girls. With nucleus cystography, grade 1 vesicoureteral reflux may be missed. We can't grade it according to the International Reflux Study, and it's difficult to assess the bladder sphincter dysenergy. It is useful to screen siblings of children with reflux, and there are centers where ultrasound is being used to look for reflux. Just another example of asymmetry of the kidneys in this patient who had a nucleus cystogram. As the bladder filled, there was bilateral reflux, a little bit worse on the left than the right, looking from a posterior approach. Patient voided. We could see that during the voiding phase, the left collecting system became more dilated and more filled with radiopharmaceutical. And finally, as the bladder emptied, there was still a little bit of residual in this left collecting system, which correlates well with this very small kidney. In this particular child, there was marked dilatation of the pelvic-calyceal system. There was preservation of the corticomedullary differentiation. The ureter could be traced, and in fact, we could see a lot of to and fro peristalsis, and coming down toward the bladder, we could see the distal ureter. VCUG demonstrated that there was no reflux during the filling phase, but as the patient was voiding, it became apparent that there was a large amount of reflux into a very dilated collecting system. And this is the post-void film where there is still residual in this collecting system. Now, early treatment is meant to eradicate the urinary tract infection and to prevent recurrences. Long-term suppressive medication with antibiotics is often used until 4 to 5 years or until the vesicoureteral reflux ceases. It's often sufficient for low grades of reflux. Some children may require anti-reflux surgery in the form of reimplantation when there is grade 5 reflux. And then there is a technique of using endoscopic intravesical injection of a small amount of material into the bladder wall behind the submucosal ureteral tunnel so that reflux can be prevented. There's a very nice article in Radiology published by Harriet Paul Teal from Boston Children's Hospital, who talked about this endoscopic treatment of vesicoureteral reflux with autologous chondrocytes. And they showed that prior to the chondrocyte injection, that there was quite a gaping ureteral orifice, and after the injection, it's a very tiny area. This is a case from Mount Sinai where we saw mounds of the chondrocytes after the injections looking quite round and appropriate. Dr. Paul Teal pointed out that there are times when there is a double mound rather than a single mound that is round on follow-up. And the absence of the chondrocyte mound or the presence of a multi-lobed mound contour is associated with persistent reflux. The mean mound volume decreases over time, and there can be treatment-induced hydroureteronephrosis, which is uncommon and is usually self-limited. Now, the upper tract anomalies include ureteropelvic junction obstruction, ureteral duplication, ureteral obstruction, and ureterovesical junction obstruction. With a UPJ, we're going to see that there is dilatation of the calyces, the infundibulae, and all of these communicate with this very large pelvis. Here's another one. There is marked thinning of the parenchyma around these dilated calyces, and there's no corticomedullary differentiation, implying a nephropathy. The pelvis of this kidney was gigantic. It came all the way down to the pelvis, as we can see in relationship to the bladder. Now, if the ultrasound shows hydronephrosis, but the VCUG is normal, then the renal function has to be assessed. And in this situation, nuclear renal scans are indicated, and Lasix washout is assessed in the form of a diuretic renogram. And this is helpful in quantifying renal function. In the normal situation, we'll see the peak and then the progressive rapid decrease in the radiopharmaceutical. In the case of obstruction, that doesn't happen, and actually the reverse happens, but there are some that are indeterminate because of extreme dilution of the radiopharmaceutical or poor renal function. Here's an example of a patient who had dilatation of the collecting system within the upper pole of the kidney and had this cystic structure that appeared to be occupying the lower portion of the kidney. On an IVP, it was apparent that there was filling in of this cystic mass with the aqueous contrast and was deviating the ureter medially. Pre-Lasix, from a posterior view, showed that there was delayed filling of this structure in relationship to the upper pole of the kidney. After Lasix, there was clearing of the radiopharmaceutical from the normal portion of the kidney, and then there was delayed excretion into this ureteropelvic junction obstruction in the region of the lower pole moiety of a duplicated kidney. Now, MR urography has been called the questionable future gold standard in pediatric urogenital imaging because of the fact that the function as well as the anatomy can be very well assessed using this. However, young children require heavy sedation or anesthesia to have MRI. It is not as available, and it is certainly a lot more expensive and should be reserved for patients who have a problem that can't be solved with ultrasound. Then there are children who come in with urinary tract infection where we find that there's a duplicated collecting system. Here we can see dilatation of the upper pole collecting system, very little parenchyma, if any. The lower pole has mild dilatation of the intrarenal collecting system. There is corticomedullary differentiation that looks appropriate. And as we follow this down, we can see that the dilated ureter is actually inserting at the level of the bladder neck. So this is an ectopic ureterocele. In little girls, it can be anywhere from within the bladder to the bladder neck to the vagina. In fact, if it's not obstructed, the little girls may present when it's in the vagina with constant wetting. In little boys, if there is an insertion into the posterior urethra, it's still inside the external sphincter and they do not have the same problems with constant wetness. Some of the girls who have an obstructed ureterocele that is terminating in the vagina may actually present with an introital mass that's bulging. Another one, simulating a simple cyst in the kidney with a normal parenchyma in the lower pole, although there's none in the upper pole, and some fullness of the lower pole collecting system. As we look at the additional images, here's the bladder. This is the continuation of a ureter that arose in the region of this large cyst and was actually a duplication cyst that terminated in the bladder as a large ureterocele. The fullness of the lower portion of this duplex kidney is most likely because of pressure from this dilated ureter, although there certainly is a higher incidence of reflux into the lower pole of a duplex system. Here's another example of a patient with a duplex system who had a very thin parenchyma around the lower pole moiety. The appearance on the VCUG was that of a drooping lily because of the fact that there is an upper pole here that is associated with this dilated collecting system superiorly. And this was a grade 5 reflux. Primary megaureter is due to an adynamic distal segment of the ureter. It's more common in boys than girls, and it's frequently bilateral. There's usually a holdup of the radiopharmaceutical if it's examined pre and post Lasix. Many of these will spontaneously regress, and surgery is usually reserved for patients who have moderately severe obstruction, if they're failing to thrive, if they have urinary tract infection that doesn't respond to treatment, or they are experiencing pain. Here's an example of a patient with a VCUG done for a UTI. There's an indentation on the side of the bladder, which turns out to be the distal ureter on the left side. And this patient also had nephropathy, as evidenced by increased echogenicity with no corticomedullary differentiation in the left kidney. And here's the dilatation of the intrarenal collecting system, the proximal ureter, very tortuous, dilated ureter, which terminated as a narrowed segment right at the end of the ureter inferiorly, consistent with a ureterovesical junction obstruction. And then there are little boys who come in with a tight phimosis that may be the cause of the urinary tract infection. Others have neurogenic bladder. They may have bladder or urethral diverticula, fistulae, posterior urethral valves, or anterior urethral valves. Posterior urethral valves are more common than the anterior type. They are obstructing folds of tissue in the posterior urethra. They can cause an obstructive uropathy. They may also be associated with renal dysplasia. The bladder wall is usually thick and trabeculated, and there is dilatation of the posterior urethra and vesicoureteral reflux. Clinically, they may have a urinary tract infection. They may present with a distended bladder, so it appears to be a lower abdominal mass. They may have a poor urinary stream. They may be incontinent. They may develop a urinoma because of obstruction to the kidneys and fractures of the fornices of the calyces. They may also present with urinary ascites as a baby, and very rarely bladder perforation can occur. In this baby with bilateral grade 5 reflux, we could see the dilatation of the posterior urethra, and this is the dilatation of the collecting system inside the kidney. On one side, it looked exactly the same on the other. Very bright echogenicity in the parenchyma of the kidney that is consistent with renal dysplasia from long-term obstruction. You can actually scan the penis to look for the anterior urethral valve, in the sense that you'll see the diverticulum that is actually arising in the region of the abnormal fold. Pyonephrosis can be shown with ultrasound by demonstrating echogenic material within the collecting system in the presence of bacterial or fungal infection. However, other material can look echogenic, such as protein or blood. In the presence of a large fungus ball in this kidney, hydronephrosis helped to outline the fungal infection, and here's a fluid debris level within the dilated collecting system. Very increased echogenicity and no corticomedullary differentiation in this tiny baby with a ureteropelvic junction obstruction. Pyonephrosis in a duplex kidney. Here's an example of what looks like a mass behind the bladder. We see a very dilated, somewhat tortuous ureter on the left side, and here's a fluid debris level. The ureter was followed superiorly. There's another fluid debris level, and we could see that it terminated in the upper pole region of this otherwise unremarkable appearing kidney. So this was pyonephrosis complicating an ectopic ureterocele that actually terminated at the bladder neck. Stones are rare in children. They can be the underlying cause of a urinary tract infection. So we need to do a thorough search for stones, especially if there is urinary tract obstruction and difficulty voiding. We try to reserve CT for patients with negative sonograms where there's a high suspicion of calculi. This patient had pain and infection, had fullness of the intrarenal collecting system, fullness of the distal ureter, a little bright echogenicity in the distal ureter above the trigone, and here we can see a little shadow and a twinkle artifact to confirm that this is an obstructing stone. Don't forget to look at the urethra. Any child who comes in with dysuria where there may be a problem with a stone lodged in the urethra, ultrasound can be very helpful. This was done through a step-off. We see the base of the penis, the shaft, the glands of the penis, and there's a large stone that is sitting right in the fossa navicularis. Now, pyelonephritis usually results from an ascending infection or reflux. It could develop from hematogenous spread. And the symptoms in the children who can express themselves are usually flank pain associated with fever. They may have nausea and vomiting and malaise. Babies may present with fever and irritability and foul-smelling urine. Well, it may be totally normal on the ultrasound. However, there may be subtle findings. The kidney could be large. There could be decrease in the corticomedullary differentiation. There may be focal parenchymal abnormalities, decreased color Doppler in an area of focal parenchymal inflammation, and there may be thickening of the renal collecting system that is more than 0.8 millimeter. In this patient, there was swelling of the upper pole of the kidney, a little bit of increased echogenicity. Here there's an actual rounded area of brighter echogenicity that correlated with this DMSA study to show a lack of uptake. And this is a nonspecific finding and must be followed about a month later to be sure that it resolves, and also to look for scarring, and also to be sure that it's not something that's related to a neoplasm. Some children will develop abscesses in the area where they've had a focal inflammatory infectious process, and so if symptomatology doesn't regress and the urine culture remains positive, repeat ultrasound should be done sooner to look for development of an abscess. Nuclear medicine may show a focal defect, may show patchiness throughout the entire kidney. With ultrasound, we may see an area that looks unusually bright, as we see here, and here there's no Doppler flow. Here we see in the article by Robin that there is mild thickening of the wall of the renal pelvis, both in this longitudinal view as well as this transverse view. Chronic pyelonephritis, we may actually be able to see differences in the contour of the kidney. This is a patient with a duplex kidney who had reflux into the lower pole, and there's tremendous thinning of the renal parenchyma. We do not do CT and MRI routinely in patients with urinary tract infection, although there are many findings that can be helpful, particularly when assessing for abscess and perinephric collections. We reserve it for those patients in whom we can't assess things as completely as we need to with sonography. Here's an example with sonography of a perinephric abscess. Here's an example of CT evaluation of a kidney that was enlarged in this patient with pyelonephritis. This is a small area of decreased attenuation, which is not enhancing on the post-contrast images. Another image on a patient who had an infection where there is actually a rind of tissue around the kidney, which is a lot better seen with the CT in this perinephric collection. Now, most females who have urinary tract infection have cystitis, and their symptomatology usually includes dysuria, lower abdominal or pelvic pain, urgency, new onset of urinary incontinence, frequency, strong foul-smelling urine, hesitancy, and hematuria. With ultrasound, the bladder may be entirely normal when the child has cystitis. There are some patients who will present with bladder wall thickening, could be focal, it could be diffuse, and particularly with a viral cystitis or a hemorrhagic cystitis, the bladder wall can be thickened. With viral cystitis, the bladder wall may actually have characteristics that are suggestive of rhabdomyosarcoma, and history will differentiate cystitis from a tumor. The ultrasound findings will typically resolve within 2 weeks after the patient presents. Here's an example of one of the many phases of cystitis sonographically. There's lobulated wall thickening. In this patient who was treated with Cytoxan for a bone marrow transplant, there was continuing problems with cystitis, thickening of the wall, septations within the bladder lumen, and with color Doppler there is hypervascularity throughout the bladder wall. Sometimes the bladder wall will develop a polypoid appearance, as we see here with this patient who had hemorrhagic cystitis, this thickening of the wall. Other patients may actually develop bullous cystitis that also can be demonstrated with sonography. Sometimes the bladder wall will look like there is a constriction and be highly suspicious for a mass, but on ultrasound we see something that looks very suspicious as well, but as the bladder fills, we see that the size of this so-called mass actually gets longer and more slender, and that centrally we can see the lumen of the bladder. No tumor would do that. And then just about 2 weeks later, these findings have completely resolved. Now, some conditions can mimic cystitis. Neurogenic bladder can have a thick wall that looks irregular. There may be a urachal diverticulum, bladder wall diverticulum. Sometimes focal bladder wall thickening develops in the presence of an indwelling catheter. With prostatitis, there can be some symptomatology that is confusing with cystitis, and at times a tumor may have some similar characteristics. Neurogenic bladder in this patient demonstrates thickening of the wall, looking very much like cystitis, but this patient could not empty their bladder. Here we see the little outpouchings from the bladder wall in this patient with a neurogenic bladder, and these are little diverticuli bilaterally in this patient with spina bifida. At first, these look like cysts behind the bladder, but as we angle the probe, we see that this is the neck of a diverticulum, and the patient had several. So in closing, I would like to just spend a few minutes on talking about how we approach the children and when we scan them, so that all of the things that we've talked about during this lecture will have the best chance to be demonstrated, and that the children will be appropriately followed so that they will have the least risk of damage to their kidneys. So in the children who are less than 5 years of age with a first urinary tract infection, females will have an ultrasound. They usually have a VCUG or a nucleocystogram, and the males will have an ultrasound and a VCUG. The reason in the males that we like to do the VCUG is that they need to have the urethra examined carefully for various things that can cause urinary tract infection and obstruction, particularly posterior urethral valves, any type of diverticulum, or stricture. At times we will use nuclear renal scanning or CT, but it is only reserved for cases in which the ultrasound and the studies for reflux are not conclusive. Now, in patients who are older than 5 years when they present with a urinary tract infection, they have an ultrasound. If the ultrasound is normal, no further imaging is done. If the ultrasound is abnormal, then a VCUG is done. And if they have a voiding dysfunction, VCUG may be done as well. In patients who are already adolescents who present for the first time with a urinary tract infection that has occurred 2 to 3 times in 12 to 18 months, sonography is usually performed at that time. Now, in terms of monitoring the children who have been diagnosed with urinary tract infection and who have vesicoureteral reflux, they will have an annual VCUG or nuclear VCUG, as well as an annual ultrasound. The VCUG to see whether the grade of reflux has increased, decreased, or the reflux has resolved. And the annual ultrasound is very helpful in looking for progressive appropriate growth of the kidneys, signs of hydroureteronephrosis to determine if it is, I'm going to fix that. And the annual ultrasound is used to assess renal growth, progression or regression of hydroureteronephrosis, and to examine for scars. And of course, the pediatricians and urologists will follow the children with urine cultures as well. So I thank you very much for listening to this, and I hope this information that I presented will be helpful to you as you examine the pediatric patients who present with urinary tract infection. Thank you.